Hello, this is Annemieke Aartsma-Rus, and I will now give an overview of therapeutic approaches that are approved somewhere in the world and that are in clinical trials. And as you can see, I will be recording this in August. It's quite warm here today, but I know that the meeting will be in October. I'll be joining online afterwards. So if you have questions about this talk, but also about whatever happens between August and October, new developments, feel free to have questions about that as well. Before going into the talk, I'll give a brief overview of my disclosures. So I'm employed by the Leiden University Medical Center, which has patents on exon skipping technology. And as a co-inventor, I'm entitled to a share of royalties. I also do a lot of consulting and advising, and I get honoraria for speaking at conferences on behalf of companies. All the money for that goes to LUMC, so my employer, and not to me personally. So with that out of the way, what will we talk about today? I'll give a brief introduction about Duchenne and dystrophin and the pathology that occurs when you have no dystrophin, because we need this when we start considering the different types of therapeutic approaches. And I've divided them in dystrophin restoration and in those targeting pathology. And finally, I'll end with a word of cautions on stem cells. And you can see this as a sort of an appendix of the talk. So starting with the cause of Duchenne patients don't make dystrophin, and I'm sure that you are aware of this. Now, what does dystrophin normally do? It connects the inside of the muscle fiber, the part that contracts, the protein skeleton that contracts muscle fibers, to the connective tissue surrounding each muscle fiber. And in that way, it provides stability. So if there is no dystrophin, this stability is not provided, and there's muscle damage during contraction. And I like to use the example of the carabiner to explain what dystrophin does, because you use this if you go rock climbing. And like dystrophin, the carabiner has two important domains that connect. It connects to your harness, it connects to the rope. And you don't need the carabiner to go rock climbing. You need it to prevent things going wrong. And this is just like dystrophin. You don't need dystrophin to have muscle. You don't need dystrophin to use your muscle. You need it to prevent damage. So if there is no dystrophin, what will happen? There's chronic damage that leads to chronic inflammation, the production of scar tissue, so fibrosis and adipose tissues instead of muscle, impaired regeneration, and with time, the loss of muscle tissue and the loss of muscle function. And this happens in Duchenne because the linker between the internal part, the skeleton of the cell, and the connective tissue surrounding the muscle fiber is gone. You may know that Becker muscular dystrophy patients also have mutations in the dystrophin gene, but they can produce a partially functional dystrophin. And you can see here, this is a shorter carabiner. It prevents you from being hurt seriously if you make a mistake, but there is still damage because you can see the bit of elastic in the middle is shorter. So the Becker dystrophins are partially functional, and that means that the symptoms start later and the progression is slower, but all these pathology pathways, so the inflammation, the formation of scar tissue, the impaired regeneration, it also happens in Becker, just at a slower pace. So that is important to remember. Now, why can Duchenne patients not make dystrophin? That is because they have a mutation. So they have a variant in their dystrophin gene that prevents them from making dystrophin. Now, normally this is the dystrophin gene, and the code for the dystrophin protein is dispersed over exons. And you can see here these exons of the dystrophin gene. There's 79 puzzle pieces that all fit together. And when the dystrophin protein needs to be made, what happens in the cell, in the nucleus? A copy is made, we call this a transcript, an RNA, and the copy is made of the exons, so the pieces containing the coding information, but also the bits in between, the introns that do not contain the protein information. So now we end up with this RNA copy, and the pieces that do not contain coding information, we call them introns, they need to be removed. And this happens in a process called splicing. So now we end up with only the exons, the pieces that contain coding information, and that is then translated by the cell from RNA into protein. And this is a very complex mechanism, a very complex mechanism, both the translation but also the splicing, and it happens in all our cells as we speak. So it's very complicated. We still don't fully understand how all of this happens, but fortunately we don't have to understand it to have it work in our cells. Now, what happens in Duchenne patients is that usually one or more exons, one or more pieces of coding information are missing. And what you can see here is 47 doesn't fit to exon 51. And that means that the frame is disrupted, the genetic code becomes unreadable. So the translation machinery will translate from 1 to 47, but then here, in 51, the code becomes unreadable. And because it becomes unreadable, the translation will stop. So now you get the dystrophin that only is the beginning half. And because it has this linker, this connecting function, well, if you have only the first half of a connector, there is no connection. So these dystrophins are not functional. And this is why these individuals with this type of mutations get Duchenne. What happens in Becker patients is also that one or more of these exons are missing. But what you can see now, 48, 49, 50, and 51 is missing. So there's actually more missing, but 47 fits to 52. So now when this is translated, the code is not disrupted. The protein is shorter in the middle because the code from 41 to 50, 48 to 51 is not there. So the protein is shorter, but the two domains that are crucial for functioning at the beginning and the end for these connections, they are there. Only the middle is shorter. So these dystrophins are partially functional. And this is why Becker patients have a later onset of disease and a slower disease progression. Now, what happens if there is no dystrophin? I said already, there will be muscle damage. And normally, if healthy individuals have muscle damage, this is not a problem. This will be repaired. But the challenge with Duchenne is that there's chronic damage. So there's chronic inflammation. And normally there's a step. First, there's damage, the inflammation cells will clear away the damage, and then repair will happen. So while this damage is being cleared, the repair system is inhibited. Now in Duchenne patients, the damage is chronic. So the repair will always be impaired. Even though there's areas of the muscle where repair should start, there's areas close by where there's still damage being cleared, so the repair is inhibited. When there's chronic inflammation, there will also be oxidative stress, and there will be formation of fibrotic and adipose tissues. And when there is fibrotic and adipose tissues, this in turn will inhibit repair. So you can see already there's a negative spiral. Another thing that happens if there's no dystrophin is that there will be less blood flow to the muscle when muscles are used. And you need blood, you need nutrients, you need oxygen when you use your muscles. So if there's not enough blood, this will lead to more damage and more oxidative stress. And you can see these pathological processes are now getting an extra activation, and things get even worse. And finally, there's too much calcium ions in the muscle. And normally calcium ions are very well controlled because they are also needed for using your muscle. And if there's too much, the mitochondria, the power generators of the cells, are damaged. So you need a lot of energy to use your muscle, and the mitochondria, the pieces of the cell that make the energy, they are damaged because there's too much of this calcium floating around. When they're damaged, this leads to oxidative stress. And of course, when there's not enough energy, that leads to damage. So you can see already all these pathways all steer away from repair and go towards more and more damage, more and more fibrosis. So muscle tissue is lost, and muscle function eventually is also lost. Now, this happens in Duchenne, but it also happens in Becker, just at a slower pace. So if all of this happens because there is no dystrophin, then of course an obvious solution would be to restore dystrophin, or to see, can we target these pathological pathways? Now there is a challenge for muscle diseases, and that is that muscle is very abundant. So 30 to 40% of our body weight is muscle. And muscle is not a single organ. We have over 700 different muscles, and they're all affected in Duchenne. So it's not enough to treat one muscle or one muscle fiber in one muscle. No, you need to try and treat the majority of muscle fibers in the majority of muscles to really have a therapeutic effect. And the sad thing also is that once muscle is replaced, once there's fat and fibrotic tissue instead of muscle, this cannot be undone. So that means the time of intervention matters. The earlier you treat, the more muscle there will be there, and the better effect you expect from a therapeutic angle. That doesn't mean that you should not treat patients who, for instance, are in a wheelchair, because they still have respiratory function, they have arm function that you might want to rescue and slow down the progression. However, you should not expect that once someone is in a wheelchair, that if you treat them with something that restores dystrophin or improves muscle, that they will get out of the wheelchair. The therapy will just act on the muscle that is there when you start the treatment. So that is important. So I mentioned already, we will go over two things: restoring dystrophin, which is at the top of the pyramid, so you expect most from that, but also targeting the downstream pathology. So we'll go over them one by one, so you can take a breather when we switch between the different therapies. So the first one I will discuss is stop codon read-through. Now, stop codon read-through is only for patients who have a nonsense mutation. Now, what is a nonsense mutation? I mentioned already, most patients miss one or more exons. However, there's also patients who have a very small mutation. So they have a single typo in their DNA. And this single typo changes the amino acid code. So normally, this is the genetic code for the dystrophin protein. You have a start signal, so the machinery that translates from RNA to protein knows this is where I have to start the translation. And at the end, you have a stop that indicates protein is finished, it can be released, and it can do its thing in the cell. If you have a typo that changes the code for an amino acid into a stop code, then, of course, what will happen is that only this part of the protein will be made, because now the cell sees this as the signal that the protein is finished. Of course, this is not a very obvious location for stop, because there's a lot of extra information afterwards. But the cell is trained to see this as stop, protein is finished. What you can see here is that the gene code is not disrupted. So here you see a small change that caused the shape of this exon to change. Now the gene code is changed and no functional protein can be produced. So these type of mutations, so whenever a mutation has deletion or insertion in the name, stop codon read-through will not work. It will only work for these typos that change an amino acid code into a stop code. So that is important to know. This only works for about 10% of patients. So how does it work? So ataluren, or Translarna is another name for it. That is a compound that can suppress the use of these stop codes. So this one can be suppressed, and then instead of no protein, you can make the whole protein. It won't work for these type of mutations with an insertion or deletion, because the wrong code is being read, and you can see this with all these asterisks. So it only will work for these stop mutations. So ataluren has been tested, and it received conditional approval in 2014 from the EMA, the European Medicine Agency, and currently it's approved for ambulant patients aged 2 years and older. It's conditionally approved, which means that the company, PTC, needs to every year show to the EMA that it's safe and that there are confirmatory studies done to show that it actually really is functional, because conditional approval you get only when there's not enough information, but there's a suggestion that it might work. So it's currently marketed in several European countries, also in Middle East and in South America. It's only for nonsense mutation, as I have said repeatedly. And as part of the condition, the company had to do extra placebo-controlled trials to show that indeed there is a slower disease progression. They also did additional studies in very young patients, an extra study to show dystrophin restoration. And once it was conditionally approved and patients started using this commercially, the company also set up a STRIDE registry to follow patients who were on the treatment in a commercial setting rather than in a placebo-controlled setting. So what happened? The first confirmatory study that they had to do didn't show that the drug slowed down disease progression, but it also didn't show that it didn't work. So then EMA said, well, based on this, we cannot say it needs to be off the market, but we cannot also say that it gets full approval. So a second confirmatory study had to be done, and the results from this are in. So this was a study of 1.5 years, and after 1.5 years of treatment, the patients who were treated walked 14 meters more than those on placebo, and 14 meters more in a 6-minute walk test. So during 6 minutes, they walked 14 meters more than those who weren't treated. So this is a significant difference statistically, but the question, of course, is this clinically relevant? That after 1.5 years of treatment, you walk only a small amount more. So that's, of course, the question. However, at the same time, the STRIDE data, so the patients who were treated with the drug commercially, were being followed up. Here you don't have a control group because you're treating the patients. So you need to control with natural history, collection of data of patients who are not on treatment, but who are there just say as a data collection effort. Based on this data, when they compared patients who were on the treatment with patients in the natural history databases, what they saw is that patients on treatment had loss of ambulation 3 years later. Now, with this information, they went back to the EMA and they said, well, we now have a significant difference. And we know from this real world evidence, patients who are on the drug commercially, that there is a delay in loss of ambulation. However, EMA said, well, this, you may say it's a significant difference, but it's not clinically relevant. And you've now shown in 3 studies, first, maybe it works, and then twice, no evidence that it works. They said, well, this real world evidence, that is difficult to interpret because you're comparing it to external groups. So there might be other reasons why you see this 3 years difference that are not due to the treatment. So based on this data, we cannot approve it. And also we do not extend the conditional approval, which would mean that the drug would be taken off the market. Now, EMA gives an advice, the European Commission then has to formalize it, and they didn't. They said a re-evaluation is needed because there was a procedural mistake. So they had to re-evaluate it, and that happened earlier this year, and the answer still is no. EMA says this we have no evidence to suggest that this treatment works. So the European Commission, again, still has to formalize this. But for now, it seems that in Europe, if things continue like this, that the Ataluren will be taken off the market. PTC also submitted a marketing application with the Food and Drug Administration, where it's currently not commercialized, with the same data to see whether they would approve it or not. And what we don't know that because they submitted this to the FDA only very recently, so in August. So with that, we will move to exon skipping. So the reason behind exon skipping, or the rationale behind this, is to try and restore the code, the genetic code. And again, we have here a deletion of exon 48 to 50, and we know already 47 doesn't fit to 51, but 47 would fit to 52. So during the splicing process, where all these exons are linked together, what we want to try for this Duchenne patient is that exon 51 is not included, that it's ignored, because then 47 would be linked to 52 and the code would become readable. Now, how can we manipulate the cell into ignoring exon 51? We can do that with antisense oligonucleotides, AONs, small pieces of modified RNA that specifically bind, in this case, to 51. Now this exon is no longer seen by the splicing machinery. 47 is linked to 52. So now a Duchenne patient has the gene code to make a Becker-like protein. So where are we at now? There's currently 4 AONs approved in the US, and they target exon 51, 53, and 45. And there's 2 AONs targeting exon 53, and that's why there's 4 AONs and only 3 exons. This is a mutation-specific approach. So depending on what your deletion is and where your deletion is, you need to skip a specific exon. So exon 51 would apply to 14% of patients, and 53 and 45 to 8% of patients. So together this applies to 30% of patients, but of course that means that it does not apply to 70% of patients. The approvals in the US are based only on very low dystrophin restorations at around 1% or even less. So again, also here, confirmatory studies are needed to show that disease progression is slowing, and these studies are ongoing. What is clear is that, well, around 1%, probably if you can increase the amount that is produced, there will be more therapeutic effects. So what people are currently looking into is how can we improve the delivery of these AONs to muscle and heart, because then we would get more dystrophin and more therapeutic effects. And another challenge is, how do we deal with the fact that we need to develop different AONs for patients with different mutations? So each AON only applies to a small subgroup. So how do we try as a field to get more AON to the muscle? Well, there's different approaches. One is to just increase the uptake in general. So to all tissues, more uptake of the AON in all tissues, and then there will also be more uptake in muscle. And you can do this by linking an arginine-rich peptide to an AON. And there's 3 companies working on this, Sarepta, PepGen, and Entrada. The challenge is, what is the tolerability? Because these arginine-rich peptides can be toxic. And we know from the studies by Sarepta and PepGen in healthy volunteers and in Duchenne patients that there seems to be some kidney toxicity. And then the question is, what is the therapeutic window? What will happen first? Will you get a really good amount of dystrophin restoration and an amount of kidney toxicity that is tolerated and managed and manageable? Or will you have first so much kidney toxicity that you cannot manage this, but still very low levels of dystrophin? And that is something that we need to discuss or discover. So far in the studies that Entrada has done, this kidney toxicity does not seem to happen, but this so far has only been tested in healthy control. So this is something that we need to see how this develops. Another approach is to say, well, can we get more of the AON specifically to muscle? And there's 2 ways to do this. We can say, what if we make an antisense gene and we put this in a viral vector, AAV, and we'll get back to the AAV and the microdystrophin later. But you can also use this to make an antisense gene. Kevin Flanagan in Columbus, Ohio has done this. The challenge then is that you need to make a lot of these different antisense genes, because again, you need to make an antisense gene for exon 2, 3, 4, etc. So that is much more complex than making a microdystrophin. But it is feasible, and Kevin Flanagan has tried this for 3 patients with an exon 2 duplication. Another approach that more companies are focusing on is adding an antibody to the transferrin receptor. Muscle tissues make a lot of transferrin receptors, so there's this transferrin receptor on the outside of muscle, and if you have an antibody, it will bind that receptor, and then this will internalize whatever is linked to the receptor, in this case an AON, it will internalize it into the muscle. So then you get muscle-specific uptake. And this is something that Avidity and Dyne are working on. The challenge here is, well, what happens if you get antibodies to the antibody? So the immune system recognizes these antibodies and starts to make an immune response to them. We don't know whether that will happen and what the consequence will be, but this is a risk. These arginine-rich peptides are very small, so you're not that worried about an immune response because they're too small. These are much bigger, so there is a risk of an immune response. And also there's the specificity. Yes, transferrin receptors are expressed at high levels on skeletal muscles, but they're also expressed in other tissues, so you may get some AONs there as well. I mentioned already the applicability, so you need to skip specific exons depending on the mutation, and the mutations cluster in a hotspot, so targeting certain mutations applies to larger groups of patients, but you can see that the sizes of the groups go down very quickly. And you can also see that most companies focus on the larger groups of applicability. So there's currently 5 ongoing trials for exon 51 skipping, and there's 3 for 53 skipping and 3 for 44 skipping. but there's much less for the exons that are less applicable. But it's also challenging because these groups get smaller and smaller. And well, this is currently the challenge that, well, you can see that if you have 5 different trials for exon 40 for 14% of patients, and also in the US an approved drug for exon 51 skipping, the groups become really small, and it's very difficult to get enough patients to test a treatment. Ideally, there would be more communication with the company so that companies focus on different exons. Of course, as an academic, as a patient organization, that would be the ideal situation. That is currently not what is happening. So I'll go now into recent updates, because I mentioned already there's a lot of trials ongoing, and you saw this on the previous slides. And most of them are ongoing in the US. Results are expected next year or the year after. So at the moment, we do not know whether exon skipping leads to sufficient dystrophin to slow down disease progression. These trials are still ongoing. What we know from press releases is that the NS Pharma trial for Filter Larsen, so that's one of the approved exon 53 skipping, they did not meet their primary endpoint in a 1-year clinical trial. And then the question is, well, does that mean that the exon 51 skipper that they developed, that it didn't work? I don't think that is what it means. I think a 1-year trial is too short, because what does exon skipping do? It slows down disease progression. So what that means is that you need time to show a slower progression. And probably 1 year is too short, because in 1 year, there's not that much progression for most Duchenne patients, fortunately. But then if you want to show less progression, probably you need a longer duration. So we don't know yet what the consequences will be of this trial not showing a primary endpoint, but I don't think that the fact that you don't see a difference after 1 year means that this treatment is not working. Then there's also reports from Dyne and Avidity, so those are both with a transferrin receptor antibody, Dyne for 51 skipping, and here they showed that there was 3% dystrophin restoration with 10 milligram per kilogram and 0.9 with 5 milligram per kilogram. And what's interesting here is that you can see the dose is doubled, but the dystrophin levels are more than tripled. And that is nice, because they're currently doing their 20 and 40 milligram per kilogram. And of course, if this trend continues, then we expect very high dystrophin levels at the higher doses. Avidity does exon 44 skipping with their AON, and recently they presented that they have 25% dystrophin increase at the 5 milligram per kilogram dose. These things are all only reported in press releases. So I have not seen the data. I don't know whether everything was done properly. So we have to see this data at face value, and they look promising, but without seeing the data and how they've done the experiments and what they controlled, it's really difficult to compare, say, between this 25% and this 3%. Still, I want to stress, this is encouraging. These are better dystrophin levels than we've seen so far. With that, we will move to gene therapy. And I mentioned already AAV, adeno-associated virus. So what does gene therapy do? Since Duchenne patients cannot make dystrophin, as they don't have a functional genetic code, what if we give the muscle cells a genetic code for dystrophin? Now, sadly, there's only one virus that can really deliver gene code to muscle, and that is AAV, adeno-associated virus. AAV is very small. That means only small gene codes fit. Dystrophin is a very big gene code. It will not fit in AAV. So what we need to shrink it by 70% to get a microdystrophin. And this microdystrophin is, of course, engineered in such a way that it has the crucial domains, but that it's short enough to fit in the AAV. So we need some viral sequences as well. So the gene needs to know that it has to go into the AAV gene particles, a volume switch so that it's produced in skeletal muscle and heart, and this microdystrophin gene code. Now, there's currently different approaches ongoing for microdystrophin, and there's 4 different microdystrophins used. So you can see here, this one is used by Sarepta and Roche. They're collaborating. and by Genethon. The difference is that Genethon uses a slightly different type of AAV than Sarepta and Roche. This one was used by Pfizer. This development has now stopped. Solid has a different one, both with AAV9, and REGENXBIO has a slightly different one again. So you will see there's more similarities than differences. So this is the part that connects to the protein inside the muscle fiber. This is the part that connects to the connective tissue surrounding each muscle fiber. And then you see that just in the middle, there's slight variability. If you ask the company, of course, every company will say, well, our microdystrophin is the best. You see there's more similarities than differences. So probably if these microdystrophins are functional, they will be similarly functional. Maybe one slightly better than the other, but there's more similarities than differences. Now, there's some considerations for gene therapy, and that is so AAV is used, and normally AAV doesn't cause disease. So about 50%, as you sit in your room, about 50% of you will have had an AAV infection you didn't know because you didn't get sick. However, if we now use AAV for muscle diseases, we need very, very high doses because we have so much muscle. And of course, the fact that normally if you encounter AAV, you get only a few viral particles. Now you inject a huge amount of viral particles into the bloodstream. So the fact that it's not causing disease when you encounter it in its normal state doesn't mean that if you inject a huge amount into the circulation, that is safe. And indeed, it can cause very severe side effects. And especially the liver has a very high exposure. And we say, well, AAV will go to muscle. Yes, it goes to muscle, but it goes to liver even more. So the liver gets a lot of viruses, and that can lead to liver damage. There will also be an immune response. Even if you suppress it, just the sheer abundance of virus that you use, there will be an immune response. And this means that if you use an AAV that you've seen in the past, you cannot now use this for gene therapy because your immune system has seen this AAV, for instance, AAV9. It has seen AAV9 in the past. Your immune system will recognize it. And now if you give such a high dose of AAV, if you have seen it in the past, this would probably be very dangerous. So that is why an antibody test is done to see if we use AAV7-4, did you see this in the past? If we used AAV8 or 9, did you see this in the past? If so, sadly, you cannot be treated with gene therapy, AAV gene therapy for now. If you've not seen it in the past, then you might be eligible for gene therapy trials or treatment. So where are we now? In Europe, Roche has submitted with the EMA the Sarepta Elevidys microdystrophin gene therapy. So it's under evaluation. It's not yet commercially available in Europe. It is approved in the US and also some countries in the Middle East. And the FDA approval was an accelerated approval. So confirmatory studies were ongoing. And these have been done. And the results are that the primary endpoint was not met. Still, the FDA expanded the approval. So while it was accelerated approval for only 4 and 5 years old, currently in the US, Elevidys, this microdystrophin from Sarepta, is approved for patients 4 years and older. There's no age limit. The approval is full normal approval for ambulant patients. For non-ambulant patients, the approval is conditional. So there the company needs to collect extra data to show that there's a slower disease progression in non-ambulant patients. And this brings, because there's no age limit, there is a safety concern. Because older patients, they will also have heart problems. They will have respiratory problems. And we know that if you have a limited buffer, all the side effects that AAV can bring about, it's very difficult to tolerate, to cope if you are older. So that is a concern. This is something that we need to study more. But just bear in mind that even though it's approved for all ages in the US, patients with severe respiratory problems, patients with heart problems, they might still not be eligible because it's just too risky to treat them with AAV gene therapy. Deletion or mutations should not involve exon 8 and 9, and we'll get back to that later. So what do we know? We know from a lot of clinical trials done by the different companies. We know from patients who've been treated commercially since the Elevidys was approved by the FDA earlier this year. We know a lot. More than 500 patients have so far been treated. We know that if you give AAV gene therapy for microdystrophin, the microdystrophin will be expressed in the muscle. And we know that if the dose is too low, the expression levels will be not enough, but we also now know which doses you need to give to get high amounts of microdystrophin in the majority of fibers at levels of 30% or more. So we know that. But we also know their side effects, and they can be severe to very severe. So with AAV9, the one that is used by Pfizer and Solid, 3 deaths have occurred, 2 in the Pfizer trial and 1 in an N-of-1 treatment for gene editing. So these side effects were severe to very severe, even involving death. The side effects are related to the dose. So the higher dose you use, the more the risk is that there are these very severe side effects. However, you need a higher dose to get enough microdystrophin levels. So you cannot say, well, let's just give less, because then you will not get enough microdystrophin. It's also age-related. When patients are older, their immune system will be more mature. But also, if patients are older, usually they are heavier, and you give this per kilogram. So if you're older, if you're heavier, you will get more viruses. And with more viruses, there's a higher risk for severe side effects. And of course, if you're older, you will already have respiratory and cardiac problems. So you will also be less able to cope with these side effects. So I mentioned the side effects. So there's side effects that are acute. So they happen within 30 days after the gene therapy. Can be severe nausea, liver damage, kidney failure, sepsis, myocarditis, so inflammation of the heart, and even death. Fortunately, the patients so far who did not die, say the kidney failure, it all returned to normal. So that is the good part. But of course, don't underestimate the risks. There's also side effects that occurred later, and that was an inflammation of muscle and breakdown of muscle, rhabdomyolysis, and myocarditis, so inflammation of the heart. And this was due to an immune response to the microdystrophin. It was only seen in patients with a deletion at the start of the gene. And why is that? Because the immune system responds to proteins that are foreign. Duchenne patients don't make dystrophin. So if we start producing microdystrophins in Duchenne patients, shouldn't they all have an immune response to microdystrophin? Well, they don't. Only these patients with the deletion at the beginning of the gene, only they have this anti-microdystrophin immune response. Now, how does this work? What we speculate is that this is the full dystrophin, this is the microdystrophin. When we say patients don't make dystrophin, this is not actually true, because there's different types of dystrophin, and especially in the brain, you have a dystrophin form that's only this last part. And 99% of patients can make this dystrophin. So this part of the microdystrophin is not new to the immune system. They've seen it, so they don't respond to it. Most Duchenne patients will have a mutation in the middle. So they will make this beginning part. It's not functional, but the immune system, again, will have seen it. So the microdystrophin is a part that they will have seen and another part that they will have seen for most patients, except patients who have a deletion here at the beginning of this clicker domain. So now these patients cannot make this because there's a deletion, and now they get this microdystrophin that has this protein part that they've never seen, and then the immune system will recognize this as foreign, and they will have an immune response. And this is why patients with the deletion of exon 8 and 9 cannot be treated with microdystrophin, because there's a risk of this autoimmune response, and then your immune response system will clear away all the cells that express microdystrophin, and then of course, well, you're worse off than you started with, because you start losing muscle tissue and you get an inflammation response in the heart. So the microdystrophin, I know that there is there's a lot of enthusiasm about it, especially now that it's approved in the US, but there's also things that we don't know. So what we don't know is how functional the microdystrophins are in humans. We know they're functional in mice, we know they're functional in rats and in dogs, but these animals walk on 4 paws. Humans walk on 2 legs, and the dynamics are different. So the fact that it's functional in animal models doesn't mean that it will also be functional in humans. This is something that we will need to figure out. What we do know is microdystrophin is not a normal dystrophin. It's very short, so it will only be partially functional. And that means that there will still be turnover. The muscle will still be damaged. It will just, if it works, be damaged in a Becker type way. So there will be slower damage, but there will still be damage. And with that damage, you will lose your microdystrophin genes. So with time, what we expect is that the levels of microdystrophin will go down, 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 down. And then the question is, when will they go down to such an extent that there will no longer be a therapeutic effect? Will that be years? Will that be decades? We don't know. But of course, if it's years, then we have a problem. Because once we've treated patients, we cannot retreat them because they will have an immune response. After you've treated them with AAV, there will be an immune response. So this is a treatment that you can give only once, and then you cannot retreat, even though we know that with time, you will lose your microdystrophin. If that time is 50 years, it's not that big of a problem, but we don't know how long it will take, and it may take less. It may take a few years. So that is something that we'll have to wait and see. Here I compare exon skipping with microdystrophin, and I will not say one is better than the other. They're different, and it's good to understand the difference. With exon skipping, we produce Becker-like dystrophin. So we know they're functional because we see that they work in Becker patients and they have a slower pathology. The microdystrophins are significantly shorter than the dystrophins that are produced in Becker. So we don't know yet whether they're functional in humans and how functional they are. If we have 30% of exon skip dystrophin versus 30% of microdystrophin, the 30% Becker dystrophin is probably going to be more functional. However, that is not what happens. What you see is with exon skipping, well, so far we get maybe 5% of dystrophin restoration. And like I said, I don't yet know how the avidity people assess them. Their results, if they really have 25% of dystrophin, of course, that is very positive news. But so far, with the results where I know that I can trust them, we get up to 5%. Well, with microdystrophin, we get much higher levels. So then the question is, of course, what is better? A little bit of a dystrophin where we know it's functional, or a lot of the dystrophin that is probably less functional, but we have much higher levels. Exon skipping is mutation specific, so depending on where the mutation is, you need to skip a specific exon, and for some patients, it's not possible to restore their dystrophin with an exon skip. With microdystrophin, it applies to most patients, except for the patients with the deletion at the beginning because of this risk of an autoimmune response. With exon skipping, currently approved treatments are weekly intravenous infusions, which is of course a high burden. With microdystrophin, it's a single treatment. The duration with exon skipping, well, as long as you keep treating, there will be a treatment effect. Well, with microdystrophin, as I explained in the previous slide, we don't know. We know that at some point you will get less and less microdystrophin, but we don't know how long this takes. Exon skipping treatment is quite well tolerated with microdystrophin. There's severe side effects seen, but they are only seen just after the treatment, so within the first weeks after treatment, and then so far there's no side effects beyond that. So I will briefly also give some information about gene editing. This is not yet in clinical trials, but it's a combination of the exon skipping and the microdystrophin. So that's why I very briefly outline it. So what is gene editing? It's a scissor that cuts in the DNA with a GPS that tells it where to cut. For muscle, we can only use the system that introduces mistakes. So you cannot use it to correct mutations as you can do for other diseases. For muscles, you can only introduce mistakes, but you can use this to induce permanent exon skipping. And that is what people are trying to do for Duchenne. So then you would have to treat only once rather than now every week intravenous infusion. So the challenge here is it works in cultured cells, it works in animal models, but will it also work in patients? Because again, also here, the treatment effect depends on the time of intervention. And there's somehow the reasoning that because you now target the cause of the disease at DNA, that this will be a cure, but it's not. If you correct the mutation in fibrotic or adipose tissue, this tissue will not start making dystrophin and it will not suddenly become muscle. So it depends on the time that you treat what the treatment effect will be, and you will need to treat muscle. So you need to treat the majority of muscles in the majority of muscle fibers, just like for all the other treatments, and you will not produce a normal dystrophin. So it's very important if people tell you CRISPR cure, sadly for Duchenne, that is not the case. You expect that at best patients will have a slower disease progression. As I mentioned, currently it's in the preclinical stage. There's no trials yet, because what do we need to improve? We need to deliver the scissor, we need to deliver the GPS system with AAV. And because it's a two-system approach, you need a lot of AAV, and well, we can't really go higher with the dose, but we need to deliver everything efficiently. So that is challenge one. There's safety concerns, high dose of AAV, but also what if there's cuts in other parts of the gene or in other parts of other genes? So we need to understand that better. And then there's an immune response to the AAV, which I explained already for the microdystrophin gene therapy. But the Cas protein, this scissor protein, that is also a foreign protein. So if suddenly a tissue starts expressing this scissor, the body will also recognize that this is not us. This does not belong here. We need to eradicate this. And this is, again, an autoimmune risk that needs to be better understood. So early stage gene editing, there's a lot that still needs to be resolved before this can go into the clinical trial stage for Duchenne. So we will now move to targeting pathology. So you can restore the dystrophin, but all the dystrophins that you restore with exon skipping or with the microdystrophin, they are only partially functional. So the pathology will still happen. So even with these treatments, you will also need to treat the pathology. But also for patients who are not eligible for exon skipping or gene therapy, targeting the pathology is not mutation dependent, so that will work for everyone. So we will start with glucocorticosteroids, which inhibit inflammation and protects muscles against muscle damage. And this is because they bind the glucocorticoid receptor. They also bind the mineralocorticoid receptor, but this is actually not something that you want, because this will increase the blood pressure, and that is not good for the heart function. What also happens if you give glucocorticosteroids is that the cortisol production by the adrenal glands is suppressed, because, well, the body sees, well, there is this fake cortisol floating around. We don't need to work. And that means that if you need more cortisol, for instance, if you have a fracture, or if you're nauseous and you throw up the steroids, that the adrenal glands cannot make the cortisol because they've become lazy and they stop making it. So then you need stress dosing, and this is very important to bear in mind. And finally, what the glucocorticosteroids can do, they can go into the cell nucleus and activate gene transcription, and this is the cause of all the side effects, or many of the side effects that you see with chronic use of corticosteroids. So the two most used steroids are prednisone and deflazacort. And what medicinal chemists said, well, wouldn't it be nice if we could make something that acts like a steroid, that suppresses the inflammation, but that doesn't have all these side effects? So they started their chemical tinkering. And if you look at this vamorolone, and you compare it to prednisone, you see it's very similar. There's some very minor differences, but the idea is that this one has a lot less side effects because it cannot go to the nucleus. So vamorolone, it can also bind to the glucocorticoid receptor. It can also inhibit inflammation. It reduces blood pressure, so that's actually a good thing. So this side effect is actually helping in Duchenne patients, but it still will suppress the cortisol production by adrenal glands. So this stress dosing is still needed when patients are fractured or don't get enough steroids into their system. But because it doesn't go to the nucleus, all these side effects that occur would be reduced. So this is the theory. What about the reality? So vamorolone, this steroid analog, has been tested in Duchenne patients 4 years and older. And what has been shown is that if you look at the efficacy, the slower disease progression in short term, it's similar to prednisone. And so far, there are indeed less side effects. So there's no signs of osteoporosis or reduced growth. However, the weight gain, which is also a side effect of the steroids, that was seen also with vamorolone. So yes, there's some side effects, at least in the short run, don't seem to happen, but others sadly still occur. Vamorolone is now approved by the EU and in the EU and by the FDA, and it's approved for 4 years and older. And there's no maximum age because the EMA reasoned, well, steroids are used by older patients and they're effective by older patients. So if this works in younger patients, the vamorolone, we expect it to also work in older patients. And now the marketing is started. So in the EU, where something is approved by the EMA, the marketing has to happen country by country, and this is now started. What we don't know is what about the long-term effects? Is it as effective as the prednisone long-term? And of course, are there also long-term less side effects? And these are things that we don't know because the treatment was only very recently approved. But so far, the fact that there's no sign of osteoporosis or growth stunting, of course, is promising. So finally, I will go into the HDAC inhibition. And this is quite complex, but we have to go back again to normal muscle regeneration. If the muscles are damaged, first, the debris, the rubbish has to be cleared away. And there's an immune cell doing this, and this is called macrophage. It literally eats away the damage. Then in step 2, there's repair. And this is done by FAPs, fibroadipogenic precursor cells. And these FAPs, they will produce the mold surrounding the muscle fiber. And then when that is done, the muscle is regenerated and the muscle stem cells will fill this mold with muscle tissue. So this is how things normally happen. In Duchenne, I mentioned already, there's chronic damage. So there's chronic inflammation, and this leads to the FAPs. Instead of making a nice mold, they make too much fibrosis, they make too much fat. And instead of supporting the muscle stem cells to make new muscle, these muscle stem cells will become FAPs themselves, and they will start producing fibrosis and fat. So this is how things go wrong in Duchenne. Why do these things go wrong? That is also because there's a system in the body that modulates how proteins behave, and this is done by acetylation. So there's a small group, an acetyl group, that can be either added or removed from protein, and that modification influences how these proteins are functional. What's happening in Duchenne is that the enzymes that remove the acetyl group, it says histones, but it should say that remove acetyl are more active. And this makes the pathology worse because removing this, it tells the inflammatory response to be very active, to be very high alert, rather than what's normally happening, dampening it so that it's not causing too much damage. It also suppresses regeneration. And it stimulates the production of fibrosis. Now, if all of this happens because there's too active removal of these groups, what if we suppress the enzymes that do this? And the enzymes that remove these acetyl groups are called histone deacetylases, HDACs. So what if we suppress this? Can we then improve the pathology? And one of these HDAC inhibitors is givinostatin. And if you don't fully understand how this works, that is fine. Just remember what it tries to do is there is a system that is overactive that stimulates pathology. Now, if we suppress the activity, can we improve pathology? So what would that look like? Again, we're in the situation of Duchenne where things are going wrong. The chronic inflammation causes damage. Well, that is because this HDAC system is too active. What if we suppress it? Then the immune system will be dampened and there will be less muscle damage. The FAPs will be reset to their normal function. So instead of making fibrosis tissue and fat tissue, they will start supporting the muscle stem cells. And because of that, the muscle stem cells will now repair rather than being stalled in the early repair, rather than going and becoming FAPs themselves. They will start to repair the muscle. Again, this is the theory. What happened in Duchenne patients? So Givinostat has been tested in clinical trials. And in the first trial, they took a biopsy at baseline and then after a year of treatment. And what they saw is that after 1 year of treatment, there was less fibrosis in these muscles compared to baseline. In each patient, there was less fibrosis. How much less? That varied between patients. Also, a clinical trial was done in ambulant patients 6 years and older, and here the primary endpoint was met. So the speed in which patients could walk four stairs was better for treated patients than for non-treated patients, and also other endpoints were improving significantly or trending. Based on this data, the FDA approved Givinostat for patients 6 years and older. There's no maximum age, and also here the evaluation with EMA is ongoing, so we'll have to wait and see what how EMA interprets these data. So in summary, it's possible in Duchenne patients to restore dystrophin with exon skipping, with AAV microdystrophin, but there's room for improvement. And also there's the approaches that target pathology, and likely, as I mentioned already, in the future, you will probably need to combine this because the dystrophins that are restored are not fully functional, so the pathology is still ongoing. So those not eligible for the dystrophin restoring approaches for whatever reason, you can still target the pathology, but those eligible for the dystrophin restoring approaches, you would treat them with both to have a maximum effect. Now, in my final few minutes, I will give a word of caution for stem cells, because in theory, stem cell treatment sounds like a really good idea and a very good solution, because what you do, you isolate stem cells from healthy people and you expand them in the lab, and then you treat them, you give them to patients, and what they will do, they will go to the muscle, they will repair the damage, and because they're from a healthy individual, they will also make dystrophin. So the theory makes a lot of sense. However, the reality is much different from the theory. And that is, stem cells do not migrate into muscle. So you inject them into the bloodstream, they will stay there, and very few occasionally will migrate into the muscle, but having one stem cell in a muscle, that's not going to undo the damage. So the efficiency is very low. And also the problem is we have so much muscle. So you really need a lot of stem cells in order to counteract the pathology. Even if you inject locally, the stem cells will stay where you injected them. They will not migrate. So there's currently no evidence that stem cell treatment is effective or safe. Well, you can use the muscle stem cells. You can also isolate other stem cells and say, well, they will then differentiate. Once they're in the muscle, they will differentiate to muscle and then undo the damage. These are even less efficient at going into muscle. So also here, you do not expect a therapeutic effect because there's abundance. You have 1 or 2 stem cells within a skeletal muscle trying to undo all the damage. Well, that's just not going to work. But there's also the so-called niche. The dystrophic muscle in Duchenne patients, there are these pathological pathways happening. There's chronic inflammation, repair is inhibited, there's fibrosis, and all these signals, they work on the muscle stem cells of the patient, they work on the FAPs of the patient, and these are negatively influenced and they don't repair, they make fibrosis. So if you now have an external stem cell coming into this muscle, what will happen? They will get these signals as well. And rather than repairing muscle, they will get also the signal to become a FAP and to start making fibrosis. So based on this, there's currently no evidence and no expectation that stem cell treatment will have any treatment effect in Duchenne patients. I know there's 2 clinical trials ongoing in Europe with stem cells. One is in Italy, and this is the local treatment of a single muscle where they inject the stem cell into the muscle and then they take out that muscle. It's a small muscle. They take out the entire muscle to study. This is not a therapy. This is research. So if you want to participate in research, fine, but there's no expectation that it will be therapeutic because the one muscle that is treated is taken out to study. And there's also one in Poland, and I'll go into detail for that one, because this is really, if you look at the data that they show in mice, if you look at the data that they show in the patient, there's a lot of wrong interpretations. And I'm not saying that the researchers doing this intentionally misinterpret this. They believe in this, but it's really easy if you believe in this to stop being critical and to fool yourself. So I'll go into this in some more detail. And these people, they publish a lot, but they publish a lot about the same thing over and over again. So the fact that there's many publications doesn't mean that it works. It just means that they do what you're not supposed to do as a researcher, that you publish the same thing over and over again. So what is the idea? The idea is you isolate stem cells from a healthy donor, you isolate stem cells from a Duchenne patient, and then you merge these 2 muscle stem cells, you merge them into a fused chimeric cells. So now you have from a father and from a patient, you have a cell and you merge them, and then they become a chimeric cell. And why do they do this? Because they say, well, now the cell has the characteristics of the patient, so the immune system will not recognize it, but it also has the dystrophin gene from the father, so it can make dystrophin. Now, how do you deliver these stem cells? Because I mentioned already, they will not go to muscle. Their hypothesis is that if we inject these into the pelvic bone during a surgical procedure, these stem cells will then find their way to muscle and start fusing. Now, if you look at the amount of stem cells that they inject and you then see how many cells you would expect per muscle, it's very, very little, but still they expect that this will have a therapeutic effect. And well, already from the rationale, you can have many question marks like, why would this work? But they claim it works. They tested this in the MDX mouse model. That's a mouse that doesn't make dystrophin. They did not use control mice. So there's no healthy mice. So whatever differences they see, they say it's an improvement, but that's really difficult to know if you don't have the healthy mice. So you see something goes up, well, you don't know whether that's going to normal or whether normal actually was lower. So that's the first thing that they didn't do properly. They also say that there's 15% dystrophin restoration in the mice. But what they mean is that 15% of the fibers make some dystrophin. And if you look at the absolute amount, it's really very, very little. So this is, again, how to look at it is different. They also say there's a treatment effect in the heart. And this is a scientific image, but I'll try to show you and explain to you what's happening. So what they look at in the mice is the ejection fraction. So how much can the left ventricle pump out? So how much blood can it pump out into the body? And then they look at baseline here, and higher here is better. And then they look at 1 month in untreated and at 3 months in untreated. And they say it goes down. So it gets worse, which is a fair conclusion. Then here are the treated animals, and these are receiving a low dose, and you see, well, it goes down with time. And here you see the mice that are treated with a high dose of stem cells, and then they say, well, it's stable. So there is no deterioration of the heart. However, if you look at this, what you can see, it's not that that there's stability and that it stays the same. It's just that at the time, at the baseline, the heart function of these mice is already much less than it was at baseline for the other 2 groups. And this can be a chance finding, but concluding that it's stable and therefore works, that is not fair, because actually what's happening, this heart function is just as bad as the mice that were not treated. It's just that the mice at the start of the treatment already did that bad. So they call this a treatment effect. I think it's just that something went wrong. In this group just happened to have very poor heart function already at the start. So based on this, I would not conclude that there's improvement in heart function, but the researchers who really believe in their therapy interpret it in a different way. So they did a clinical trial in 3 patients, 2 6-year-olds and 1 15-year-old, with the donor cells from the father and the patients. And as I explained, the cells were fused, transplanted into the pelvic bone under anesthesia. And after 6 months, they see that the ambulant patients improve functionally. However, we know from the natural history of untreated Duchenne patients at age 6, you expect them to improve. This is the time where patients learn skills, they improve, their North Star will go up, they will grow up, so their 6-minute walk distance goes up. So this is expected without a treatment. However, again, the researcher interpreted it, this is due to the treatment. So what you, of course, really would like to know is how much dystrophin do these patients make in their muscle, but they didn't take a biopsy because they said it's unethical. It's ethical to take the biopsy from the father and the patient to isolate the cells. It's ethical to put the patient under anesthesia to inject the cells in the bone, but it's then unethical to take a biopsy and actually see whether the treatment has worked as they claim it has. But that's what they claim. So authors conclude that this approach is therapeutic based on these data. And I mentioned already, they have many different publications, but it's all about the same data. I think based on this data, there's no evidence that this treatment works. Yes, the patients improve functionally, but patients of 6 years old, they will improve functionally anyway. So with that final bit of caution against stem cell treatment, I want to thank you, and I will join online in case you have any questions about this or about new developments that happened between August and the time of this meeting. Thank you very much.